Hello. Hello. Hello.
Hi, good morning. Good afternoon, sir.
Can you see my slides?
Yes,
Am I audible?
yes, sir, you are audible. Can you speak again, sir? And can you?
Yes. Can you hear me?
Yes. Yes, sir.
Slides are visible?
Yes, sir. Yes, sir. Can you just change the slide for second slide, please? Yeah, it's going. So you're all set to go. If you want to start, you may start directly, sir.
You can just brief about the program and then we can start. Okay.
Thank you.
Over to you, Rupa.
Thank you, sir. Hello. Are we clearly audible? Can I request somebody to just thumbs up if you can? Thank you, sir. So, with that, thank you very much. Welcome you all on the first session because we know that we all are amid that medical and the war type of emergency. With that, we really wanted to, as a nurse, being in the nurses month, we should also be ready for all that national demand. With that, we really thought of designing some program where we nurses can also contribute in this type of situation, and therefore we actually try to customize a program which is called mass casualty management program exclusively for the nurses. With that, I, on the behalf of WHO Collaborating Center for Emergency and Trauma Care, I welcome you, all of you, and thank you very much for joining us on the first series of mass casualty, where today we are going to talk about the overview. With that, I request our director, Professor Sanjeev Bhoi. Most of you know about him, and sir will be starting with the addressing you all, and then hand over to Dr. Tej Prakash Sinha. Over to you, sir. Sir, please.
Thank you, Rupa, and welcome you all. And you know the pretext of developing this module on mass casualty management. You know this is an unprecedented situation in our country, and it's a very fragile situation where this is a moment of notice. What I say, this is actually called a moment of notice, where only once in lifetime we get opportunity to contribute to our, anyway we're contributing every day, but this is an extreme situation. We need to contribute without going to the forward post, to save our country. Here we'll be saving more lives, at our own place and respond to this extreme situation in a moment of notice. So this course module was designed and conceptualized and designed and being executed in a series of multiple modules, and and it is very nice, really heartening that most of you people have responded to it, and almost I can see almost more than 100 people I can see just joining in, pouring in, because this is what we can do for our nation. So I urge you to take it very seriously, because physically we cannot train much people. I am sure we can do through our interaction a small initiative from our side. If you participate well and go back and try to implement it in your own emergency departments or the hospitals in collaboration with your head of the institute, as well as the acute care physicians, because everybody has to respond. Organize your mass casualty management in the hospital. This will be you can say tribute to our country. With this, now I hand over the platform to Dr. Tej Prakash Sinha, additional professor and co-director, my co-director in WHO Collaborating Center, to start the program. Thank you.
Thank you very much, sir.
Thank you, sir. And definitely, yes, we are in that situation where we need to be prepared for any kind of eventuality which may happen due to this war, or I would say this is not one time kind of preparation which is happening, or this is the first of its kind which is happening, but we do encounter these kind of scenarios, be it a natural disasters, man-made or otherwise. I am very sure that many of you must have witnessed such kind of scenario where many number of patients has reached to your hospital, be it a diarrhea outbreak, be it some other things, be it bus collapse, a bus has turned down or hit some other, or be it a train accident. So these are not uncommon, and I am very sure that many of you must have uh, faced such kind of scenario. I am Dr. Tej Prakash, work as additional professor at Indian Institute of Medical Sciences, AIIMS Delhi, in Department of Medical Emergency Medicine. So let me take you through the day-to-day emergencies and how we organize the system of emergency care, a brief about it. Then we will try to understand what we do at hospitals during these emergencies. And then we'll take you through the real journey of mass casualty management. So any kind of emergency which happens at scene, or it can be at your home, or it can be at a road, like road traffic injury, or it may be a chest pain which occurred to some workplace or something like that. So anyone who is having this kind of emergency, they usually visit the hospitals via some kind of transport. Sometimes it is what we call as a medical transport, that is the ambulance service. So the site of happening, we call it as scene, and then a travel plan or visiting to hospital. So some kind of transport, many times our own vehicle, many times like in road traffic injuries, the police used to bring some victim from roadside, and many times the ambulances itself. So scene, transport, and the third part is what we provide at the hospitals. So we call them as facilities. So scene, transport, and facility. These three very important component is required, what makes a system of emergency care. It is beautifully depicted and elaborated by World Health Organization, and this is one of the framework very commonly used in many presentations or many kind of deliberations, discussions. So we call it as scene, transport, and facility. So altogether, they create a emergency care system. But in healthcare, why we are focusing so much on emergency care system? If we see every year, almost 1.5 lakh people are dying due to road traffic injury only. And that constitute only 10 to 12%, mind it. Just imagine 10 to 12% means 1.5 lakh. If I just extrapolate to 100%, how many lakhs will happen? So lot many patients are dying due to conditions which can be managed by good pre-hospital and emergency care system. And one of the estimate by World Health Organization says that almost more than 50% of deaths and 90% of disabilities or disease adjusted life year lost can be addressed just by improving the pre-hospital and emergency care, mainly the emergency care. So this is such an important aspect of healthcare. So any patient comes with some kind of serious condition which reaches the hospital. So let me take you through the hospital, and especially where these patients used to visit. We call them as emergency areas, emergency units, emergency rooms, and in bigger places, we call them as emergency department. Earlier, they used to say casualties, but nowadays it is casualty is not the right term. So this is emergency room. So any patient can come to your emergency. I am putting few injuries only. So like right now, we are facing a scenario where war-like situation is there. That's why I will be emphasizing more on the conditions which can reach to us, or the scenarios which can reach to us. So you can see one side, so gunshot, one side is amputated limb on right lower side. A kid is having some impalement over the head. A person is having some impalement over the abdomen chest area. So these are not uncommon which visits to emergency. So what we do when these patients used to come, say they have been transported to your emergency. Once they reach to hospital, especially the emergency area, we think the things or the what we do, we can just summarize in 3 words or 3 R's. So first is recognizing that this patient is having some kind of serious issue which need to be addressed, or it is not like elective or can be followed up in OPD or a OPD kind of patient, but it is something which need to be addressed right now, maybe serious, maybe not that serious. So recognition. So first R is recognize. The second R is whatever this patient requires, that kind of treatment, which includes assessment, medicines, diagnostics, those kind of things. But what we do initially, we call them as resuscitation. So saving the limb, life, organ, resuscitation. So recognizing that this patient is having emergency condition, very sick, not that sick, so recognition. Then whatever the problem is there, we are going to address those issues, helping that patient. We call them as resuscitation. So recognition, resuscitation, and then if you are having those facilities or capability, then it's fine. If capabilities are not there, then you have to refer. So इसको थोड़ा और सिंप्लीफाई कर लें हम लोग. तो हमने पहले बात करी, आपको एक कॉमन चीज की बात करी कि अगर पूरा इमरजेंसी केयर सिस्टम की बात करें हम, तो जहां पे इमरजेंसीज हो रही है वो जगह है, अस्पताल जहां पे इलाज होगा, और किस तरीके से लाया गया, जिसको हम लोग ट्रांसपोर्ट कहते हैं. तो सीन ट्रांसपोर्ट फैसिलिटी. कोई भी पेशेंट, ऐसे पेशेंट आ सकते हैं आपके पास. अब यहाँ पे हमने क्या करा, 3 काम करा. उसको रिकॉग्नाइज किया, सीरियस कितना है, नहीं है, इमरजेंसी है, नहीं है. फिर जो उसकी रिक्वायरमेंट थी इलाज की, ट्रीटमेंट की, वो हमने करा, जिसको हमने बोला रिससिटेशन. और अगर सुविधा है तो बहुत अच्छी बात है, अगर सुविधा नहीं है, उसको और कोई इलाज चाहिए, तो आगे जाए, उसको हम लोग कहते हैं रेफरल. सो रिकॉग्नाइज, रिससिटेट, रेफर, ये 3 काम हम करते हैं. अब करने के लिए क्या क्या चीजें हमें होनी चाहिए, क्या हमें चाहिए अस्पताल के अंदर में. तो एक तो चाहिए आपको कि भाई जहाँ पे पेशेंट आ रहा है वहां कोई रिसीव करे, स्ट्रेचर हो, सामान हो, व्हीलचेयर हो, जैसी जिसकी जरूरत। फिर एक कोई देखने वाला हो वहां पे, क्विकली उसको देख के समझे सीरियस है, कितना सीरियस है, कम सीरियस है, जिसको हम लोग ट्रायज भी कहते हैं, है ना। उसके बाद जो एरिया जहाँ पे उसका इलाज होना चाहिए, जैसे मान लीजिए किसी को ऑक्सीजन की जरूरत है, मॉनिटरिंग करनी है, वेंटिलेशन की जरूरत है, तो वो उस एरिया में उसके इलाज के पूरे साजो सामान वहां पे हों, और हम जो इसका इलाज अब करेंगे इमरजेंसी में, उसी को हम लोग कहते हैं रिससिटेशन। जब आप रिससिटेशन करते हैं तो थोड़े मॉनिटरिंग डिवाइसेस की जरूरत पड़ती है, ऑक्सीजन हो गया, मेडिकेशंस हो गए, कुछ और इक्विपमेंट हो गए, सप्लाईज हो गए, इन सब चीजों की जरूरत पड़ती है। सो जैसे ही हमने इलाज शुरू किया, हमारा पूरा आइडिया ये रहता है कि इसकी लाइफ, लिम और ऑर्गन सेविंग, ये टारगेट होता है, इसकी प्रायोरिटी पे काम करें। फिर जैसे ही थोड़ा सा आपने रिससिटेट किया, हेल्प किया, फिर आपको इस बीच में आपको इन्वेस्टिगेशन की जरूरत पड़ेगी, चाहे वो सिंपल इन्वेस्टिगेशन हो, ब्लड टेस्ट हो, या एक्सरेज हो, या हायर इन्वेस्टिगेशन की भी जरूरत पड़ सकती है, जैसे सीटी स्कैन या कोई और टेस्ट। अब आपने शुरुआत का इलाज कर लिया, लाइफ, लिम, ऑर्गन सेविंग का काम शुरू कर लिया आपने, स्टेबल हो गया पेशेंट। अब आप ये सोचते हैं जांच वाच की रिपोर्ट देख के, जो भी आपका टीम है, हेल्थ केयर प्रोवाइडर्स, आप देखो ये तो ऊपर में हेल्थ केयर प्रोवाइडर्स हैं, तो नाउ आइडिया ये होता है उनका कि क्या ये ठीक हो गया। जैसे मान लीजिए कोई हाइपोग्लाइसेमिया लेके पेशेंट आ गया था, आपने ब्लड शुगर दिया, ठीक हो गया। कोई सीजर लेके पेशेंट आ गया था, आपने सीजर कंट्रोल कर दिया, ठीक हो गया। कोई ऐसे ही माइनर कुछ लेके आ गया था, कटवट लेके आ गया था, आपने उसको ड्रेस कर दिया, पेन मैनेजमेंट कर ली, है ना, वुंड केयर दे दिया उसको, तो ठीक है, ही कैन बी डिस्चार्ज। बट समटाइम्स आपको जरूरत पड़ती है ऐसे पेशेंट को, आपको लगता है कि नहीं ये डिस्चार्ज नहीं हो सकता है, इसको आगे इलाज और चाहिए। जैसे मान लीजिए कि वो पेशेंट जो रॉड वाला है, जिसको अंदर रॉड चला गया है, इसको तो छुट्टी नहीं कर सकते, तो देन यू हैव टू एडमिट दोज पेशेंट्स। मे बी उसको एडमिट करके, सिंपल है तो वार्ड भी जा सकता है, बट ऐसा वाला केस जो था रॉड वाला, इसको तो ऑपरेशन थिएटर चाहिए होगा। सो नाउ जो भी स्पेशलिस्ट उसका इलाज करेंगे, उनके साथ हमें बात करनी पड़ेगी। सो सो वी हैव टू स्पीक टू देम, वी हैव टू डिस्कस विद देम, जो स्पेशलिस्ट हैं, whoever इज स्पेशलिस्ट, चाहे वो सर्जन हो, ऑर्थोपेडिक्स स्पेशलिस्ट हो, न्यूरो सर्जन हो, जैसे
Sir,
रिक्वायरमेंट, वट एवर इज रिक्वायरमेंट।
yeah. Sir, I'm so sorry I'm interrupting you. We are regularly getting messages that kindly be in English because many of our participants are from the southern part and other parts. They're really,
Okay, so
yeah,
I
I'm so
got so many
sorry.
messages to
Yes, for Hindi, I know.
for
So, sir,
Hindi.
we are planning to have a bilingual. So, one session would be in Hindi and one session would be English. So, I prefer
Okay, no
request you
issue,
to
no
be in
issue.
English,
मैं
sir.
बीच में I will
Yeah,
try
you
to
have to be
speak some
bilingual.
Hindis also, no issue. So overall, what I was saying is that you have to do 3 hours, recognize, resuscitate, and if your facility is not capable, you have to refer. Taking that further, you have to talk with your various departments wherever you feel that this patient requires admission. Like if I take you through this scene again, if I see this first one, the bullet injury, likely I am going to talk with the neurosurgeon. लग रहा है सर इसको हेड शॉट है, एंड देन if the patient is requiring operation theater or operation, they will take it to operation. Or like this patient is having amputation of the leg just below the knee, so maybe the orthopedician will think right now he don't require operative, just wound care, debridement, or those kind of things. Or so depending upon the need of the patient, these specialists or the concerned departments or the doctors, they will think to admit either to ward, or if the patient is sick, to ICU, or they may require urgent operative intervention. So first operate and then admit to ICU or wherever they are. But many of those patients are not that sick. They require some kind of monitoring or maybe just minor procedures or minor work. and they can be discharged from the hospital or the emergency department itself. So this I told you that this is the panorama what we do in day-to-day practice, and this is the journey of the patient which happens from the emergency department to the various care areas, ward, ICU or OT. Okay. So now, when we manage sick patients in emergency, so we follow certain kind of algorithm protocols. Okay, be it trauma, be it non-trauma. Overall idea is to save the life, organ or limb. That is the overall idea for those sick patients. Okay. In triage, we say them as red patients. Okay. So there is an approach. So this approach is widely taken from the trauma care, but it applies to non-trauma sick patients also. Okay. Like any unconscious patient used to come, then you have to again follow ABCD. So airway, spine, breathing, ventilation, circulation, hemorrhage control, disability, then exposure, environment control. But if you see this is the same what you do in your nursing practice. So let me tell you, this I learned a few months back, your nursing care plan, it is so beautifully written and you learn in such a nice way that I feel that I as a doctor may not be fitting that much what you fit as a nurse in emergency care. Because see, if you see, I have just written few words downside that what you do in nursing care plan is assess, okay, then you diagnose something, then you plan, then you do something that is intervene and you have to reassess. And you are more focused towards the patient or the complaint. It is not the diagnosis oriented. Like we as a doctor, we think about, oh, okay, he is having liver damage, or okay, he is having some broken hand. But you as a nurses, you think more about the patient centric. So, sir, he is having pain. Bone baad mein. So it's a very, very good. And in any sick patient, re-evaluation is key, which you do in your nursing care plan. So be it trauma, non-trauma, we follow the protocol or protocolized approach, ABCD way, that is the physiological way. Okay. So, and the whole emergency care is integrated, barring few centers like our AIMS trauma center is different. Some more hospitals you might have seen that cardiac center is different, this center is different. But by and large in country, in many of the medical colleges, district hospital downward, everything is integrated and it need to be integrated in a country like us. So integrated approach. Okay. Now you have undergone or taken a view emergency में कैसे कैसे process होता है, how the patient is being processed, क्या काम हम करते हैं, what we do in emergency, what kind of need is there in emergency. So if I say that I have to organize the emergency or reorganize the emergency, the fourth are what I require. I require some space, people who can work, that is the staff, and the things what I need or the patient need. So space, staff, supplies. Okay. This is usual I am talking about. I am not talking about something mass casualty or those kind of things. I am talking about day-to-day practice. Day-to-day practice. Like in emergency, what kind of space you have? So various care areas. Okay. Then what kind of people you have? Doctor, nurses, security, administrators, those kind of people. Then various kind of supplies, equipments, consumables, non-consumables, those kind of things you have. And we organize ourselves in such a way that the day-to-day need of my emergency can be met. That means I must know how many pediatric patients are coming, how many adult patients are coming, so that I can think pediatric के लिए ये gown चाहिए होगा, adult के लिए I require the bigger gown, or likewise in emergency what we think, how many very sick patients will come, how many mild cases will come. So we call them as red case or resuscitation requiring, where you have to do everything to safeguard life, limb, organ. And those patients who are having mild kind of illnesses, they can be just treated and can be discharged back safely. They don't require an investigation. They most of the time they don't require observations even. So they're the mild cases. Okay. Some of the cases you may have where you require monitoring, some investigation, or both. Okay, they will stay for some time. Many of them will be discharged. Some of them will be admitted. Some of them may turn into sick, and then you have to take them to resuscitation and admission. So, meaning to say, we have three category of patient: red, yellow, and green. So once we know that these are the three categories, then I can prepare myself like that. So I am giving you one more figure. 70, 20, 10. Just remember this figure. 70, 20, 10. So if your emergency is having 100 patients, then you will have 70 green patients. Those kind of patients who are having minor kind of illnesses or injuries, can be done simple things. What you require for injured patient? Minimally injured patient. You require some pain management, dressing, then maybe suturing, some kind of splinting for broken, or just for support. Okay. So these kind of things you require, and then you discharge them. Those patients who require some kind of monitoring, some investigation, they are not that sick, but still require some monitoring devices, some person to monitor. But the sickest patient will require most of your resource. Because they are sick, you require more manpower, fast, doing everything very fast, okay, to safeguard the life. Then you require a lot of resources like suction, oxygen, drugs, this, intubation items, bag mask, so many of the things. So number-wise, rates are just 10%. In common scenarios, day-to-day scenarios, you will have 7 to 10% rate. So that's why I'm giving you a figure of 10%. 70% of them will be having mild or minor kind of things. So green. So red 10, yellow 20, and green is 70. So if you are a master manager, in day-to-day practice, if somebody can handle those 70, so that you can utilize your resources in a better way to focus on those 10%. And next is the 20%. So 70, 20, 10. Okay. To organize these things, what we required? Space, staff, and supplies. Okay. So what I will do now, right now we are having 215 participants online, and many of them might be at YouTube also. So let's have a 5 to 7 minute, 7-minute pause. 7-minute pause. And I am requesting you all to make a diagram on a plain paper, or whatever paper you have right now. You just grab one paper and pen. Make an emergency department wherever you work or wherever you have seen the emergency department, the areas. Okay. So one diagram is showing various areas. You can just make a simple one. Does not go in that detail. Make a simple one, like this is the arrival, this is the triage, this is the red area, green area, something like that. Whatever you have seen, maybe minor procedure room, plaster room, something like that. Okay, and one side you write your manpower. What kind of manpower you used to have, like a staff. So create your space, your staff, and just wrote 4 or 5 key things. Like if you have drugs, so you just write drugs. Equipment, just write word equipment, that's fine. Okay. So just make one page your own emergency care area depicting this space. Just one corner you can write about the staff, what kind of staff you have, how many, and then some broad supplies. Okay. So first part, 5 minutes you do that, and then in 2 minutes you try to draw some line that a sick patient comes, where that patient goes, and from there where the goes, something like that. Just 2 things. Okay, so right now, what is the time, Rupa? We have to give them 7 minutes.
Yes, sir.
And
So
then
it
we will
is,
come back.
yes, sir, 6:30, 1. So
Okay, say
6:37 would be
drawing.
okay?
So this is drawing. So give another minute, couple of minutes. So let's resume at 6:40. Okay,
Done,
is
sir.
it fine? And meanwhile, somebody is having questions. They can just park the questions in the chat box. Okay. So we are just taking a pause for a bit, and again resuming at 6:40. Okay, this is now your time. Okay.
So once everybody would be ready with their drawings, can we request everyone to show it on the screen so that we can click a photograph?
That is good idea, but will they able to share?
So they are sharing, and I'm so glad to see such a
Yes, they are
wonderful
sharing
drawing.
in. Yes, I'm watching the
Yeah,
chat box.
they
Very
are
good.
putting lots of efforts actually.
So that way, I feel that if I would have asked my colleagues from various part of the country, they would have failed. So so it's very good. That's why we say that our nurses are the main people who know about everything what is happening inside the hospital. ED for this instance. Excellent, excellent. I can see uh, Salu, Momita. Okay, then Reena, Elena. Very good, very good.
So can we request ma'am and sir, whosoever has drawn already, can you put a paper like this in front of your screen? So we can just have a capture it and share with all of you. Yeah. So Shyam, when I say please show, kindly do the needful. Yes. Can we request everyone? Yeah. Thank you very much, Mala ma'am. 3. Yeah. 1, 2, and 3. Whosoever can open their camera and show their screen, please do the needful. Yeah. Can you take a picture? Thank you. Thank you very much, ma'am and sir. Yeah. So over to you, sir. Thank you.
Thank you, thank you. So many pictures are coming. Still, Rohini has shared. Very good. Thank you, Rohini. Some are very good at drawing, but some might not be that great. Don't worry. Most important is that you know your area, you know the staff and supplies also. So this was just an exercise so that मैं आपको एक बार फिर से just quickly memorize करा दूं where you work. Okay. Okay. So just remember that 70% are minor one, that is the green, 20 is yellow, and 10% is red. So before moving to the different scenario, that is the mass casualty scenario, let me ask you to visualize your own day-to-day practice scenario. इमरजेंसी में हमेशा भीड़ होती है, स्टाफ कम होते हैं, लोग ज्यादा होते हैं, पेशेंट ज्यादा होते हैं, ठीक है. और some day it is very cool, especially let's say after the midnight time, the number of patients pouring in is less. Then you have more number of people than the patients. So that happens. But the usual behavior of the patients are what? The green can speak a lot because उसको तो ज्यादा ज्यादा कुछ प्रॉब्लम है नहीं, उसको चोट नहीं लगा है, ज्यादा चोट है नहीं, हल्की फुल्की है. So that's why the green patients having milder or minor kind of problems, that's why they can shout a lot. But the sickest patient cannot speak, they cannot shout. But the sickest patient will require more effort, timely effort. So it is again the concept is right efforts in right time by right people through right supplies. Okay, that is the key. In day-to-day practice, what we do, every patient is having some attendant which is coming inside. Okay. So we don't bother about their sitting places or the attendant sitting places. The number of patients which are coming and the number of staff is somehow synchronized, or we have adapted for the scenarios. Even this is same for the supplies. Now let me take you through a scenario, what we call as mass casualty. So first, what we will try to understand is what is mass casualty. Sometimes we loosely say disaster. Sometimes we use a term multiple casualty. Okay. So if I talk about disaster and disaster management plan, so it is not only the health which is being organized. It is holistic approach. Okay. Disaster term we use when the things are totally out of control, overwhelming. Like we had earthquake in Nepal. Right now we had earthquake in Myanmar. Okay. So system has gone down because they also collapsed in earthquake, and the requirement is overwhelming. Okay. So that is the disaster kind of scenario. But if I talk about a hospital setting, let us understand a bit different way. One scenario is day-to-day practice when some patient is coming. So at one point of time, one patient came, a doctor, nurse, paramedic is managing this case. Then again, the second patient came, the third patient came, this happens. So that is one scenario. Sometime the number of people you have and the number of patients you have which need to be managed is a bit equal or a bit more. So with the same supplies, staff, still you can stretch yourself and manage. Okay, so one is day to day when the staff and supplies are ample and patients are coming 1, 2, 3, sometime 2, sometime 2, 3, something like that. So that is day to day scenario. Another scenario is the amount or number of patients you can take care at one point of time is exceeding, but not that much. Still, you can manage some management of this patient, some talking with that patient, some doing with that patient, something doing. So that is the scenario. We call them as multiple casualty. When just by small stretch, you can manage the numbers. But if these numbers are much higher, which requires extra kind of resources, way to approach the process, the management, the things to address. Okay, so big number, like if your hospital is having, emergency is having 10 beds. So at any given point of time, you are ready to manage 10 beds because you have aligned your manpower, resources, and other things with that. So if you have 12 patients, 13 patients, still you can manage by putting additional stretchers which are already there. So that condition is multiple casualty. 10 is usual work. 13, 12, 13 is stretched but still manageable with the same approach, same way, same resources. But if the patients are 50, 60, 100, and you have to do something, then you have to follow some other way to approach it. And this condition, when you have this kind of numbers, we call it as mass casualty scenario. Mass casualty scenario. And we are limiting ourselves to hospital care, especially the emergency room or emergency unit or emergency department. Now you are going to manage a large number, okay, with the same resources at one point of time, but later on other resources will come, but to start with same resources, but you have to change the approach. You have to change the approach. That is the mass casualty. Let's watch one video what happens during these kind of scenario, what we call as mass casualty scenario. Okay. Just I'm playing this video. So this was the Iraq war. Just see how the people are coming, how many people are coming. See, one ambulance is outside. See, he's coming, bringing the patient. Stretcher is going inside, and you can see the numbers: 8 victims and 15 other people came inside. Okay, another one patient is being brought by 3-4 people. So again, 12 victims. This is Iraq war. So you have seen this video. See, 30 patient and almost 70 other people. So other people are the attendants, bystanders, helping people. So just imagine you have 30 patients, but altogether it is 100 people inside. So it is not uncommon in other kind of mass casualties when happens. Okay. So what kind of differences this scenario brings to us? So I told that in day to day, this is around 3-4 minute video. So in those 3-4 minutes, you have seen that almost 30 patients and 68 non-patient people went inside the emergency room. Whatever size of emergency you have, you cannot accommodate in such a small span of time. The things will be shattered, everything will be messed up. Okay. So idea is that this kind of scenario will pose a lot of problem. One is your workspace is gone because 100 people are inside. Everything is mixed because they went inside, everybody is going inside. It's very difficult. Okay. So chaos, so many people inside, everything is chaotic inside. So let's think that what kind of patients during these disasters or mass casualty scenarios we will have. Currently, I will take a purview of the war kind of scenario. Okay. So most of the time injuries you can see at the war time or even earthquake, it is almost similar. Building collapse, almost similar. So suppose if you have 100 patients during these kind of scenarios, if you have 100 patients, 80% of them are going to have minor injuries. Like we learned 70-20-10. So here 80% is mild. And 20% will have serious kind of injury. So some of them may be life-threatening, some of them will be limb-threatening, some of them will be organ-threatening. Some of them may not be that kind of threatening, but injury is not mild. Okay. So here is 80-20. Just remember that 80-20 rule. Okay, 80% mild, 20% severely injured. So overall, my idea or the concept of mass casualty says even in that kind of rush, so many numbers, these patients who are severely sick or injured, they should not be missed. They must get some kind of care which cannot be the standard of care, some way optimal care, so that we can save their life, limb or organ. That is the overall idea. Okay. So idea even in rush, भीड़ में भी ये पेशेंट खोने नहीं चाहिए. हमें इनको पिक भी करना है, ट्रीट भी करना है. So we are not going to miss these patients. We have to approach in a way so that we can save all these 20% patient or most of it. These mild patients, 80%, though they are big in number, even if we don't bother about the care, they are not going to die. But still we have to provide the care. But I'm just making your thought process that even in that kind of mad rush, high numbers, we are going to safeguard the limb, life, organ. Okay. So again, understanding that these sick patients are going to eat up your 80% of resource. So 20% of patients are going to eat my 80% of resource. Okay, it is same like Pareto, PDSA Pareto principle, 80-20. Okay, so keep in mind that these are the sick patients. They will require high amount of staff, equipment, supplies, almost 80%. But we have to safeguard their life by provisioning, not in a standard, but still some kind of optimal care. Okay. Now, when you have, how you are going to approach in a different way. So what kind of problem we are expecting in this? One is the numbers, high number. Okay. So what high number will create? High number will create mismatch in these 3S: space, staff, supplies. Okay. So that means we require more space to accommodate more number, because my emergency may be 50 bedded and I have received 100 patients. So I require certain space. Second is staff. So to start with whatever staff you have to start with that, but same time, you have to pull in other staff, organize the staff. You will have other staff reaching from wards or other places coming to you. Use the staff in a smart way. Reduce the workload of staff. How? We are not going to do those things which are not required during that period. Like somebody asking you कि sir suture निकाल देना है. Somebody is asking that plaster is already planned for removal. I have came to emergency, यहीं remove कर दो. Somebody came for police removal. I will don't go for higher investigation. I will cut down those investigations so that I can make my staff in a good use, unburden them from those unnecessary things. Okay. Then supplies. So 70% minor injuries. So I have to think how to match the demand of those 70%, demand of these 20% patients. Okay. And so this we are going to do by various mechanisms. So some process management, some organizational management, logistic management, okay, job distributions, maybe task sharing, task shifting, those kind of things also. So these are the ways by which we will address. So let us take you through the key steps which we make during these kind of mass casualty scenarios. Okay. So first and foremost, all patients are going to come to your emergency. That is the gate of entry inside the hospital for for every patient. That means I have to evacuate the emergency areas. Okay. So all those patients where decision has been made, waiting for admission, waiting for discharge, okay, waiting for shifting to ICU or ward, these all patients will be shifted in priority. So what we do, we first create a new resuscitation bay because the sickest patient will come to the resuscitation bay. So either the same area or same red area where you work in day-to-day practice, you just vacate those few beds, send all these patients to backside of red area or directly to ICU or somewhere, okay? But vacate this area, make it available for the new patient who is coming to this area. It's just like a fire. Like during fire, wherever fire is there, you just try to evacuate that area from the fire, away from the fire. So similarly, we are going to keep that resuscitation bay free for saving life, organ, limbs. Okay. Similarly, the other areas also you have to vacate. So all those patients who got the treatment, where decision is being made, all of them need to be shifted out of the emergency unit. Okay, but shifting so many patients will take hours and hours. So what we will do? We create another space, or not creating, just designate some space. Like many of you have made your emergency, like you have corridor on backside of emergency or right or left, or some space near the emergency. You can shift these patients to that place and ask the ward people, ICU people, OT people to come there and take away these patients to their destinations. Because your manpower is required for carrying the newer patients who are coming after the disaster or mass casualties. Okay. That means on near to the emergency, I have to create a buffer zone or handover zone. Okay. So evacuate all these patients to the buffer zone or handover zone. It is good to keep sick patient or red patient to one place, in nearby place only, but one place. And there also segregated these yellow patients. If treatment is completed, just dispose, send them back home or admit, do something, but don't keep inside the emergency. Okay. So now what we will do, area is vacated. So all patients are shifted. Second is all the empty beds, stretchers, bed, whatever is inside the emergency, send them to the gate or the reception area where the patients used to come, or the entry gate. Why? Because if the patients are coming, they will be coming on those beds. So they can use that beds, they will come from there. Otherwise, you have to ask some staff to go inside, take the bed outside, and then again take the patient. So you cannot make them to and fro. Okay. So evacuate the emergency room, send to buffer, from there they will go. So that is the buffer zone concept. Create the resuscitation or make the resuscitation bay or red area resuscitation beds available for the newer patient. And same way you create a green zone. So maybe other part of your emergency, if it is a big one, then you can just create one area as green zone. Or otherwise, ideally we used to say that during mass casualty, the red area is whole of your emergency. So whole of the emergency is your red area. And some nearby area can be created as green zone. Because in green, you don't require so many things to be done. What do you require in green? Minor pain management, suturing, okay, wound related things, splinting. And in war, you may require some blast related issues like ear examination, eye, sometime oxygen, some fire has happened at that place. So some oxygen. So minimal things. So you can just create that green zone, which is not mixing with the red zone. idea रहना चाहिए. They should not mix, otherwise again chaotic. So idea is from the gate itself, the patient can go to green and can go to red. Okay. So evacuate and make the space available. Now, another space you require for the relatives, because now you cannot allow the relatives, like you have seen in Iraq war, Karbala, 68 relatives or other people and 30 patients. So then you have to create some space where they can sit and you can make them updates about the patient or something like that. Okay. Now you require more staff. So where these staff from other areas or from whom they will come and report. So we make a space or some area which is designated for the newer or other staff who is coming to help us. We call them as a staff pooling area, where the staff will come, they will stay there. Somebody will tell their job, you go there. ICU is having less number of nurses or doctors, you go there, work there. So that is the staff pooling area. So family zone, staff pooling area. Then other is very important is this media people, they will come. So you must have smartly planned some space where the media people can sit. They can know the details about the patient, but it should be away from the patient care area, near to the admin. It is better to keep them as near to the admin so that they can get the informations in a right way. But same time, they should not be disturbing inside, because they try to take some video clips and those kind of things, some interviews. That is not good. They will disturb the care. Okay. So I am telling you, emergency, whole emergency, try to keep it for red sickest patient. Then create a green zone where you can just treat, shift, or discharge, treat, discharge, treat, discharge. Since you are already running emergency, some patient must be there. So take them to a zone where you can ask the ward people, ICU people, OT people to take them from there. So that is the buffer zone or handover or transfer zone. You just leave the patient there, 1 or 2 minimal number of staff, and somebody will come, they will take away. So buffer zone. So buffer zone, family zone, media zone, red zone, and green zone. So these are the zones. So space. Staff, again, whatever staff you are having inside the emergency, you have to mobilize. Security, the HA, the nursing orderlies, sanitation staff, administration related staff members, the nurses, the doctors, paramedic, all of them is required. Okay, so so these are the areas, zones I was talking about. Okay, sometimes you are going to overwhelm, then you have to vacate your area. So you might need to shift to other facilities, especially ICU is always full. Then to create some ICU bed, you might require to shift some patient to some other facility even. Okay. Mortuary is very, very important. Many times in blast, missile attacks, wars, they used to bring the body parts. So you have to keep them for identification. Okay. So again, you have to think about mortuary, extended role of mortuary, where a lot of dead body can be kept. So you have to plan that zone also. But overall idea is, whatever will happen, there must be a unidirectional flow. Like if you see in this picture, you are coming inside the emergency area or inside the hospital premises through emergency. You reached the triage point. Now, from here, they have directed either to this green or this red zone. And from there, you are further segregating these patients requiring just admission, wards, ICUs, OT, or maybe sometimes you're overwhelming, you can shift to other facility. Or sometimes they will reach the red zone, declared date, and they will reach the mortuary, or directly mortuary if some body parts are coming. Okay. So unidirectional flow is very, very important. That's why we have to create all those spaces, the flow. You have to always think about the flow. Okay. So these are the various areas which is required. Okay. So additional zone. Now, what additional things we require? So as I told, human resource. Okay. So now you have, you require staff for red zone or resuscitation bed. What kind of staff we require? Doctors and nurses, but preferentially those who are master of all. That means if I have to choose a doctor who can man my one resuscitation bed during mass casualty, he should be able to manage airway, intubate, ventilator adding, giving some those kind of drugs, running all whole code of trauma, okay, putting ICD, doing all sort of, so all kind of skills, knowledge, management skills he must have. So that can be one person who can handle one resuscitation bay or bed, not bay, bed. Similarly, one nurse. So one resuscitation bed, the team will be one doctor and one nurse, but both of them are capable of doing whole lot of things required for resuscitation of that patient. Okay. So that we have to think how many such kind of persons I am having at that point of time. So that many number of resuscitation beds I will create. Like if I talk about my trauma center plan, so we have planned for very initial moment, time zero. When something is announced, the people who are coming from outside or wards or other places, they will take some time. Usually we don't pull suddenly from ward ICU or OT because they have to also work there also. If they will not vacate the wards, how I am going to send these patients from buffer zone? So at time zero or initial say 15 to 30 minutes, whatever team is there inside the emergency, they have to work or manage. So out of those team, I will ask one doctor, one nurse, you man resuscitation bed number 1. If I am having another set of doctor and nurse, I will say you man resuscitation bed number 2. So that is red. For managing red, since the event of mass casualty is common, like suppose missile attack happened or blast has happened, the profile of patients who are sick, we are going to have those trauma patients with certain things. So it is always good to keep those items in a way so that I can manage these patients easily. So creating that kind of cart, we call it as red kit. Like if you see the purple one, okay, ABCD, usually you manage, you keep your crash cards, okay, but many times we feel a lot of things inside this. But whatever you will do in red area at that point of time, just keep those things. Don't keep so many things. Okay. So it is good to have that kind of red area kit ready-made kept somewhere, like you keep in disaster cupboard. You make those kind of kits, and once announced, they will just pull. So the team of one doctor and nurses, they'll pull one set. Okay. So maybe one set for 2 beds, like one crash cart in between 2 beds can suffice. Similarly, in green, what we require? We require a patient come who need to be examined to some kind of monitoring devices. That patient who is coming to green, so at gate just we see walking, you go to green, non-walking, you go to red. This is the usual. Okay. But this walking can have some sharp nail or some bullet here, may deteriorate after some time. So they need to be recognized there, and from there they will be shifted to red. Okay. Some patients may not be green, may not be red, they might be yellow. So we will just shift those patients to buffer zone, and from there they will go to ward. Okay. So you require green area kit So in green kit, what we require? Some wound related sutures, dressing materials, debridement solutions, okay, that handheld instruments. If you are expecting that burn smoke is there, then you have to keep some oxygen supply. In blast injuries like bomb blast, like it has happened. So there may be eardrum ruptures. So you must have otoscope to examine. Sometime you will have due to flame or something is coming, eye injuries. Then you must have something for eyes, like eye wash. Commonly we do washings, okay. And if photophobia is happening, just we take the water paper glass and just put here and tape it. So eye is safeguarded. Okay, so these things you require. So you make a kit where these things are kept. We call it as green kit. Okay. But during mass casualty, one doctor is doing the management thing, one nurse is doing management thing, or some nurse is helping to give the supplies. Some person is documenting like administration people. Some person is taking the stretchers. So these are the healthcare providers. But many times I am having this dress. Some patient, walking patient might be having some this kind of dress. Then we are going to mixed. So we keep some vest or identifier. So you must have some jacket. Some more things like the light can go, like it happened in Amritsar, it happened in the Kashmir areas, it happened in Kutch area where the everything is blackout. So now you have to manage what you will do. Suddenly somebody has switched off the light. You might be having emergency light, but again you have to. So you must have some torch, light source, some job card, so that so these all other things not related to care, but very important for management. We keep in a kit what we call as mass casualty management kit. So if you see this one, this is the MCM kit. This is the triage kit. This is the red kit ABCD. This is the green kit. So these kind of well organized supplies you require. Okay. So apart from this, we require some other management related people. So may not be initially they are available. Some of them who are available, they can take a role of incident commander, resource suppliers or resource lead, some who is guiding about the treatment, so clinical lead. And later on, once your seniors, administrators, they will come, they will take over the roles. Okay. So just see how the things are changing during the mass casualty scenarios and how you are mobilizing or organizing yourself as far as space, staff, and stuff is concerned. And very, very important is at that point of time, you have to shift your task. And if I think my nurses are best for managing my green, okay? So I will keep one person who can just look after the process. Flow कैसे चल रहा है, इधर slow तो नहीं चल रहा है, इधर सामान तो नहीं घट गया है, क्या हो रहा है नहीं हो रहा है, overall. But the nurses can do the basic suturing, the debridements, the splinting, the basic eye wash. These all can be done by nurses. So green zone, which is the major burden, 80%, can easily be taken away by the nurses. If I talk about triage, now it is a global standard that triage is one process which is nurse driven. So nurses can do the triage, resuscitation, or whatever you are having, you think who is the best, and you make the job cut, or the jobs can be shared in that way. So task shifting is very, very critical and crucial to optimize your human resource. So these are the various kits. You can see I have just narrated what are these kits. Apart from this, The admin kit is also there. Admin kit, what that admin kit is having? Map of the city, where it has happened, how much time it will take, nearby hospitals detail, communication chart, that means the numbers, phone numbers, police phone numbers, this phone number, that phone numbers, the suppliers number, the store people. So all those things they used to have. Okay. So this is the something very specific to mass casualty. We organize ourselves in that. So very important is this communication. If your system is communicating very well with each other, then probably there will be not an issue. Like how many patients came inside the emergency room, how many patients are shifted to OT, OT is free or not, ICU, how many beds are available in ICU, okay, how many manpower came. So all these kind of communication to relative, communication to other hospitals. So all these are very important. So communication is key, even for preparation. Like if I say how I start my communication, so the first patient of like some missile attack has happened, some first patient came to me. So I am working inside the emergency. So I will inform the administration and same time I will activate MCM. Let's prepare ourselves for mass casualty because now we are expecting. So there is one communication for all the team, whosoever is working. Mass casualty plan activated. Okay, mass casualty plan activated. So let's prepare ourselves. So like you got the information, you went ahead with the plan. So first part is let's prepare ourselves to receive these mass casualty. Okay. So that we call as heightened preparedness. So everything is up and above. Everyone is knowing that yes, some big number of cases is coming. So let us prepare. So everyone is prepared. So preparation will have three things. Set, SET. Initial I am talking about SET. So S is for security. So just secure your entries and exit. Otherwise everybody will pour in. सब घुस जाएंगे अंदर. Media पहले घुस जाएगा because victims will take time because they are waiting for ambulance. But once the media will know, they will reach the hospital before they are reaching. Okay. So security, patient flow, directions, these all you need to manage. So set, security. E is for evacuation. So जितने भी patient city में हैं, whatever number of patients you are having, just try to vacate them. Ask the wards to free the beds. Ask the ICU to create the beds. Ask the OT to cancel the non-important cases or hold the non-important cases and create some OT free. Okay. Whatever empty bed is there inside the emergency, just send them outside near the entrance. Let the patient come on those beds. So we just divide walking, non-walking. Walking, no bed, no wheelchair. Non-walking, go on bed. So information received, activation plan, first part, heightened preparedness. First patient came, activated. Now you are full blown activated. Everybody is taking their role. So everything is up and above. Okay. All are communicating with each other. Everybody knows their roles. Job card is clear cut, given. Okay. And you have overall a command system, what we call as the incident command system in emergency scenarios, like mass casualty scenario, where somebody on top who is looking at the hospital level and beyond hospital level, somebody is looking the clinical part of emergency that we call as clinical lead. So usually the medical superintendent or the principal or director, whosoever is designated at your place, one person who can talk beyond hospitals, inside hospital to all big departments or other departments. Okay. Those who are taking care of clinical things and ED. So there will be the clinical lead, usually the emergency department faculties or senior doctor. Resource lead, our senior nursing colleague in the emergency department is the best as a resource lead because she knows everything. She can mobilize the things. Though she requires support from stores, so the incident commander or the big boss will help them. Same time, somebody should take care of security. So the incident commander will ask the security personnel, "Sab theek kya? Placement ho gayi?" He will check. Okay. So clinical lead will guide the red zone, triage, red zone, green zone. Okay. So again, set security, evacuation, and triage. Triage you do day to day, but we will take you through the triage in detail. But just one ad for triage. Just we divide from outside. Walking idhar chalo, green. Non-walking aap idhar jao. So that is very, very critical. So while activation, set security, evacuation, and triage. So triage is this triage I am talking about. Send them to outside the gate of emergency and let them segregate from there itself. Okay. So, so this is how a different way to approach creating new areas, getting few more healthcare providers, staff or other staff, allied staff, getting the resources well organized to the point or as per the need. Okay. So creating that kind of system, staff, whosoever is coming, they know their job card. So job card is given to them. You are having various kits which is required. So this is how we match the demand of a mass casualty, thinking about 80-20. So 20% red, 80% green. So this is how, in nutshell, I have taken you through the common emergency day-to-day activities, day-to-day practice, and how we change ourselves during the mass casualty. Okay. So this was all for today. So we can take few questions. So Rupa, over to you. If you have a few important questions, we can take those questions. Okay, so we are having our colleagues from JIPMER. We are having people from our colleagues from Apollo Chennai. Welcome, welcome. So, yes. Any specific questions you've gone through, Rupa? So just
Yeah. So there was only one question where that one of the sir or ma'am were asking ki how to manage with the suboptimal supplies. So that's what I just over to you, sir.
okay. See, what I'm talking is that whatever you are having at that point of time, like sudden bomb blast happened, like a missile came near Delhi, it reached near Delhi, but thanks to our army that they just shut down. But suppose something happened, earthquake happened, so the people will rush to your emergency and you require certain time to pull in these resources. So whatever resources you are having at that point of time, you have to manage with that resources initially. Even if you have in your hospital, like in COVID times, we had a specific requirement. We had our resources, but still it was very less as far as the COVID patients are required. Okay. That means we have to understand few principles of mass casualty management. One is during mass casualty management, it is a different care. It cannot be a standard of care. It will always be a bit lower than this standard. We try to match the optimal care. In emergency, what you used to do, you do so many things. But during those disasters, like let's say a person is having fractured arm or forearm. So in usual day, you put a wooden splint, then next you go for X-ray, then you bring back to emergency, then you apply a slab or plaster cast, POP. But during mass casualty, what I will do, I will don't go for any X-ray. Clinically, it is evident that there is a fracture. I will put a wooden splint, ask him to come tomorrow or day after tomorrow in my OPD. I will not go for X-ray. Pain management, splintage, simple splintage, discharge. Come to my OPD. So I am reducing the work. I am just giving the then required care. So that is one big way by which we match our resources with the demand. We don't do everything. Like you cannot go for the cosmetic suturing at that time. Just think about what minimal I can do so that he is not going to get further harm. That kind of thought process. Okay. Even in resuscitation, we do minimal things like patient requires intubation, I will intubate. But I will not go to get the CT from emergency itself. Rather, I will send this patient to ICU and ask them ICU people that baki sab cheez aap karo. Similarly, if I am having a doubt, I am not going to ask the surgeon to come down and give the decision. I will straight away send this patient to OT after resuscitation to OT. Let the surgeon decide inside the OT whether they want to operate, yes or no. And from there, they will shift either to ICU or ward or to operate. So that way, actually, we are curtailing our works also and limiting to those works which can save limb, life, organ, or minimal kind of care which can salvage those patients, green patient discharge. So that is how we try to match the demand. Okay.
Thank you very much, sir. As we
Yes,
are exceeding the time, so quickly, I'm having another question. Please just
Yes.
give answer as short as brief. Do we need isolation room? How to treat infectious patient when it comes to the mass casualty, sir?
See, again, I have taken you through a war kind of scenario, which is very similar injury related scenario. But yes, it can be a biological emergency like COVID also. So in day-to-day practice, we used to have certain area where isolation can be done. If you don't have, you try to designate some place where you can keep these kind of suspected patients to start with. Okay. So if you don't have, you just keep earmarked. If something happens, like open tuberculosis can come to any day in emergency. So you have to think where I have to keep. If you are having an information, some biological event has happened, then you have to think like COVID, convert the whole center in that kind of, so infected like COVID positive one center, something like that. So that way we can address.
Thank you very much, sir. So if you allow, can we close?
Sure,
Yeah.
sure.
So
I
another,
hope, yes. Go
yeah.
ahead, Ruth.
Yeah, so last question is, how about the having a counseling room in the emergency? So that we are going to cover in the future session. That was I was about to
Yes,
say,
but
sir.
just to
Mhm.
add, if you have, it is always good to have some person who can give counseling, because these green patients are going to be discharged from there, and they will have that kind of just the image of that war or that kind of scenario where life is about to go. It is always good to have some kind of person who can give psychological support. But sadly, in our part of world right now, we don't have that kind of scenario where we will get so many people, and same time we cannot have that much of time to hold those patients. So that means the idea is whosoever is the care provider, they must give some psychological support at each station, I should say. So all those staffs would be giving some kind of psychological support at all places wherever you meet, where you will get a chance.
Yes. Yeah. So thank you very much, sir. Actually, many people were asking the same question, like, do we have a code? So definitely, it is a right time, and it is actually a right practice to have a code in hospital, just like a code blue, code red. We can have a code, especially for the disaster. Any hospital can opt the color as per that. This is a totally management and internal organization protocol call. So please, and if you don't have such code so far, like disaster code. So this is the right time to make a disaster code, sir and ma'am. So just to add, thank you very much, sir. It was a very informative session, and I'm so delighted to see all that compliments. And they all are thanking for the wonderful information in the simple language. So on the behalf of WHO CSET, we thank you for appreciating our this session. And if you like it, we really wanted to have a series of this session. So today we just cover overview of mass casualty management for the nurses. Next Friday, we would be like after one day on Friday, we would be having another session on triage where we will be talking how to do triage in a normal scenario. And then we will be having the another session, alternate day on triage in mass casualty. So if you really wanted to join us, most welcome with the same link, and Monday, Wednesday, Friday, 6 to 7:30. With that, thank you very much once again. And if at last you want to say some final words, sir, over to you.
So just to say that Minister of Health has come up. We are the Center of Excellence for Mass Casualty Management in country, and we are the WHO Mass Casualty Management WHO Academy certified course runner also. So very recently we have got certification from WHO also. So the news is that Minister of Health is already working out on the national standardized code and trainings. So course is already being created. The protocols and other things are also being created. So in coming months, you will see a lot of information, good information and national standardization will follow in coming time. So that is the news from our side. So all codes, which code, how to call out, how to activate, this all will be there in coming time. So thank you very much. Thank you. Thanks for joining us. It's very many thanks. Thank you.
Thank you very much. All the very best. And if you want to continue with us, so please do watch and log in on Friday. We will be sharing triage next session. With that, thank you very much for sparing time for the national emergency. Over. Thank you.